Hello, good evening, and thank you for that introduction, Lowell, and thank you for the invitation to join you here. So over the next hour and 15 minutes, maybe even an hour and a half, I will be sharing some information with you that I hope really begins not only perhaps for some of you to change the way that you've thought about dementia and Alzheimer's disease, but really the intent is to change it, because for those of you that are out here in a role as a caregiver for somebody living with dementia, I think this way of thinking has the potential to actually make your job easier. So as Lowell mentioned, I've been doing this work for quite some time. I work in the Alzheimer's Disease Research Center at Mayo Clinic. I've now been there for almost 2 decades as a co-investigator in the Outreach, Recruitment, and Engagement Core. And while I truly respect and am awed by the work that my research colleagues are doing in trying to identify a cure for this disease, or at the very least to truly have an impact in really slowing down the progression of the disease. And I know that's what they're doing at this very moment. I know that's what they do tirelessly every single day. But my focus is a little bit different. And my focus, and where I've really maintained excitement and passion, and even more so in the last number of years, and I'll tell you why in just a moment. But my real focus and passion is about improving the lived experience for those who are today living with this disease. Part of the reason why I'm passionate about it and excited about this work is because you'll hear today when I talk that there are absolutely some things that we can do to improve the lived experience for those living with the disease and the families and the care partners who surround them. What's even more exciting is that for the first time, I think, in at least the 20 years and maybe in history of research funding, the NIH, the National Institutes of Health, has set aside some real dollars in the millions, unprecedented, for care and service research. This means that we're really investing now in finding some therapies and some ways to improve the lived experience. So with that, I thought, as we're kind of winding down the day, and it's a little bit later in the afternoon or early evening, I just start with a brain quiz, a teaser, just to kind of get you thinking about something. And the first question I have for you is perhaps pretty simple, but maybe not. What do you think is the #1 risk factor for Alzheimer's disease? Yell it out.
Age.
Wandering, age, falling, diet, hypertension, diabetes. Oh my gosh, we have a very informed group here. And for any of you who might have heard the press releases last week from the Alzheimer's Association International Conference that took place in Chicago, I was there, as well as the Alzheimer's Disease International Conference that also took place in Chicago last week. One of the most talked about research studies, something called the SPRINT study, actually began to show with a fair amount now of evidence the significant association between high blood pressure and Alzheimer's disease or dementia. So one of the things I'm going to be doing over the next year or 2 or 3 as I talk to audiences like this about reducing risk factors is to also make sure I'm talking about and sharing this data with people about reducing and managing hypertension. However, that's actually not, as we know it today, the #1 risk factor for Alzheimer's disease. And interestingly, in this audience, for the very first time, as I've been asking this question to audiences now for probably 8 or 10 years, There was actually somebody in the audience who yelled out the right answer. I've never had that happen. So if you would stand up, because the number one risk factor is age. Oh. Age, yeah. The number one risk factor is age. Some people think that's a little bit of a trick question, right? But here's the reality. For many, the journey of aging will include the reality of dementia. By age 65, approximately 1 in 7 is experiencing changes in the brain. But by the age of 72, 1 in 3 is now experiencing measurable cognitive loss. And for those who live to be 85, about half of us in this room who live to be 85 will probably be living with some form of dementia. So when you think about the word dementia, what images, thoughts, words come to your mind? Share a few with me. Confusion. Memory loss. Depression. Fear. Anxiety. Disorientation. Agitation. Denial. Yeah. A lot of what you said is up here. Pretty common thoughts, words that come to people's mind when they think about the word dementia. And in fact, if you go out and Google dementia, here's some things that you're going to see. Some of you may have heard or be familiar with warning signs. If you Google dementia, you're probably right away going to find something that looks similar to this. You'll see things that talk about people with dementia misplacing things, about challenges they have, about confusion they have, about decreases in certain thinking and reasoning skills, challenges in problem solving, losing abilities, changes in mood, new problems, trouble understanding, withdrawal, difficulty finishing tasks. Here's something else that you might see. Some folks like to put dementia into different stages. You might hear something called dementia stage 1, 2, 3, or 4, and they sound like stage 2, forgetting certain things, stage 3, more difficulties at work, stage 4, reducing the ability to do certain things, stage 5, needing help, stage 6, needing more help, stage 7, now things get pretty severe. I am painting a pretty daunting message, right? But the bottom line is, I know this is the message that's out there. These are the kinds of images and thoughts that culturally we're pretty used to. So here's a study that was done by the Alzheimer's Association International a number of years ago. And it asked this question: do you think there are negative associations about people with dementia in the country where you live? And if you can read it, it's about 75% say yes. There are negative associations about people living with dementia in my country, in my community. 24% of people with dementia in this study reported concealing their diagnosis, not wanting anyone to know. And 67% of people with dementia reported that they do not feel included or part of their community. Why is this? It's because of the way that we have learned about dementia through the media, through Google searches, and through the medical community. So the medical community has created what's referred to as the biomedical model of dementia. It's a way of thinking and understanding dementia through the lens of healthcare and medicine. And this is what it looks like. The biomedical model of dementia describes it as a group of degenerative diseases of the brain, viewed mostly as incurable. In other words, not much can be done. It's focused mostly on losses and deficits. It's policy heavy, focused on the costs and the burdens of care. And up until really recently, most all of the big dollars have gone and been directed toward drug research. Some of you who have yourself have dementia or have someone close to you with dementia may be able to identify with some of the things up here, especially perhaps during your journey of trying to receive a diagnosis. Because one of the things that I hear far too often from families is that they go in seeking some answers to what's wrong, and if they're, and I call it lucky enough, if they're lucky enough to have a physician who is willing to listen and share an honest and timely diagnosis, that's one part of the equation. But the other thing that sometimes happens in that visit with the doctor, if a diagnosis is received, is something that sounds like, well, you have Alzheimer's disease. You should probably go ahead and stop living life pretty much the way you have. Get your affairs in order and come back next year and we'll see how you are. That's not all that unusual. Here's the problem with that. The problem with the biomedical model of looking at things is it ignores the subjective experience of the person living with the disease. It looks mostly to drug therapy to provide well-being. And I think one of the reasons sometimes healthcare providers are a little bit leery of giving an accurate and timely diagnosis is because they don't have an effective drug in their back pocket, ignoring the fact that actually well-being may not have anything to do with taking a drug at all. The other pitfall is it looks at institutional disease-based approaches to care. And it sees distress, some people call them behaviors, as a manifestation of the disease. It sees irritability, anger, agitation as being caused by the disease. And I don't buy it, and I'll tell you why as we go along. Major pitfall of this model is it stigmatizes and disempowers individuals. There's a woman by the name of Kate Swaffer, and I just was with her a couple of weeks ago in Chicago for Alzheimer's Disease International. And if you Google Kate Swaffer, S-W-A-F-F-E-R, you'll see the 2 or 3 books that she's written, by the way, after receiving a diagnosis of Alzheimer's disease. You'll see her blog, you'll see her newsletter. But the thing that happened to Kate Swaffer, and she was young when she received a diagnosis of Alzheimer's disease, I believe she was in her 50s. But she was one of those women who went into the doctor's office, he or she told her she had Alzheimer's disease, and said to her husband, you may want to start looking for a day program for her, as well as a nursing home, and then get your affairs in order. Kate didn't buy that very well, And in fact, she calls it in her books and in some of the things you'll read about Kate if you look her up, she calls it prescribed disengagement. In other words, the physician basically prescribed her to disengage from everything she was involved in and take a back seat and just let this disease then run her life. Another gentleman who really began to coin this idea of person-centeredness and empowerment is a psychologist by the name of Thomas Kitwood. And Thomas said, once people are labeled with dementia, we automatically position people as being less capable than they are. Another friend of mine, Michael, said, all of a sudden, when his neighbors found out he was diagnosed with Alzheimer's disease, they looked askance when I mowed the lawn. Like somehow, just because I was diagnosed with Alzheimer's disease yesterday, that I can no longer mow the lawn today. He also said former colleagues stopped calling to get together. I lost my mind, not my words. So, a new perspective, a different way of looking at things. And I'm not offering up this new perspective because I want you to leave with rose-colored glasses and that I don't recognize the struggle and the challenge and the devastation that are associated with this disease, because I do. Because in my role, I meet with families very shortly after they receive a diagnosis. And then I continue to stay connected with them years and years, sometimes even a decade or more. So I get it. I get the ups, the downs, the struggle, the emotional impact, the losses. I get it all, as much as I am capable of, not having the disease myself. But in spite of all that, there is a perspective and a different, real, honest way of looking at this disease that I believe is actually far more accurate and truthful and leads to better outcomes in the area of well-being. So this new perspective looks at the whole person. It looks at assets rather than deficits. When I go out and ask people to tell me about dementia, I get a whole list of what people living with dementia can't do. Why? Because that's what we go. When we go out there and we go to lectures or people talking about dementia, we take classes or we read books for the most part, or we go online, what you find is a lot of information about what people can't do. What you don't find a lot of is information on what people can do, what parts of their brain are less affected, and how we capitalize and take advantage of that. This model does that. This model looks at well-being as a primary outcome, instead of a primary outcome in the medical model, which might mean that somebody scores a point or two better on a test by taking a drug, perhaps. This well-being model has more to do with the quality of one's life versus improving a cognitive score by a couple of points. And this new perspective has us rethinking about the word dementia. And I think when I show you this new dementia, this new definition, it perhaps will be the opening for you to seeing dementia in a different way, one that actually may make life better. Dementia. Dementia is a shift in the way the person experiences the world around him or her. Hold that, because this definition may change things. Let me show you how. With this shift in the definition, we seek to understand. Because when you say something like, well, that person is angry because they have dementia, case closed. We think there's nothing we can do because they have dementia. But when we think of dementia as a shift in the way the person perceives their world, then we seek to understand. Because what we want to do then is to begin to think about, well, what is it? How are they perceiving their world? And once we start to ask that question, we begin to uncover solutions. What we also do with this definition of seeking to understand, another way of thinking about seeking to understand is empathy. With this definition, we are beginning to employ empathy. Rosalie is a caregiver that I got to know a number of years ago. And she was caring for her husband, John, who was diagnosed with Lewy body dementia. And I got to know Rosalie and John very early in his diagnosis. They came and they were involved in a program we have at Mayo Clinic where folks are with us for 50 hours. So it becomes very much a relational opportunity. And Rosalie had been keeping a journal. And in fact, she had been keeping a journal even before her husband's diagnosis, as things began to change. And Rosalie, through the years, her husband just went into hospice a couple of weeks ago, has offered up her journal to me to use in ways that might be helpful to others. But this is one excerpt from Rosalie's journal, and she says, I kept trying to imagine what it must be like to be in John's shoes, slowly and surely losing abilities, self-esteem, status, and self-confidence. When I was feeling frustrated, I would tell myself, if he could, he would. So an example of employing empathy. So with this shift, this different way of thinking about dementia, we seek to understand, which allows us to see solutions rather than problems. This definition is also a focus on changing abilities rather than a fatal disease, right? When we say the person is experiencing a shift in the world around him, that means we're seeing a shift and changes in abilities. It allows us to see assets before deficits, and it places value on improving well-being, not just a cure. Let me dive in a little bit deeper to illustrate this. There's a gentleman, you may know him by the name of Atul Gawande, and he has a book called Being Mortal. And one of the things he says is this. Atul says, we've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but it is larger than that. It is to enable well-being. So let me focus on a couple of things. What happens when we focus on changing abilities rather than just seeing this as a fatal disease? And what happens when we focus on assets rather than deficits? And one of the things, rightfully so, that you might be asking at this point are, well, what assets? Tell me more, right? I want to know, what are the capabilities that people living with dementia maintain? So this is sort of my oversimplistic way of thinking about memory. So you can think about memory really in two different ways. There's two different types of memory. That's a better way to describe it. We have implicit memory and we have explicit memory. So if you look on the left-hand side, these are implicit memories. Another way to think about these are memories, these are things that we do without really thinking. They're kind of below our level of consciousness. They're produced in a certain area in the brain. These are things that we do, for example, riding a bike, or when you leave here tonight, getting in your car, or tying your shoe, right? Most of you, when you leave tonight and get in your car, are not going to put a whole lot of thought into, now, how do I drive this car? Let me think about it. In fact, your mind is going to be in a zillion different places on your way home, and it's probably not going to be about what's going on in the car. The other type of memory that we all have is referred to as explicit memories, or things that are more effortful. It's also produced in a different area of the brain called the hippocampus. And this is our ability to sort of draw up facts and knowledge. So it might be me saying to you, I asked you to read chapter 5 last night. Tell me, Mary Kay, what you remember from chapter 5. And what's happening in Mary Kay's brain right now is her hippocampus is firing, because that's where she has to go to retrieve that information about something she just read. So here's the problem, and that is that ability to retrieve something you just read is not working so well in people who have dementia. And we know that, right? You ask somebody living with dementia to talk about, something that might even seem pretty simple to us, like what did you have for lunch this afternoon or dinner yesterday? And you probably will find that they struggle. They might make something up, but probably they're going to struggle with that, because by asking that question, we're focusing directly on the very part of their brain that isn't working so well. But we tend to do that with people who have dementia. We tend to say something that starts like this: do you remember? Right? So instead, where do the assets live? The assets live over here, because in these implicit memories, or these procedural memories, or automatic memories, are well preserved in people living with dementia. Let me give you some examples. So procedural memory, automatic memories happen because of overlearned skills and habits. When you go to brush your teeth in the morning, or however many times a day you go to brush your teeth, it's a pretty automatic behavior, right? And in fact, sometimes it's so automatic. Has this ever happened to you? You're a couple hours into your day and you're like, did I brush my teeth this morning? And we do it without thinking. You might remember Glenn Campbell, and if you saw his documentary, I'll Be Me. Here you saw this person, right? I think he had 140 some on-the-road tours after being diagnosed at Mayo Clinic with Alzheimer's disease. And when you see him off the stage in this documentary, you see a gentleman with very profound memory and thinking skill loss. And then you see him on stage, and he is performing for the most part flawlessly, especially when it came to his guitar. And there's a segment in the documentary where he has like a 7-minute guitar solo that is extraordinary, that's all just coming up from memory. And then you see another clip in the video where my boss, Dr. Peterson, is asking him, where are you right now? What kind of a building is this? Who is the president right now? And he didn't know what kind of a building it was. He didn't know that he was at Mayo Clinic. He didn't know that he was in Rochester. And when he asked who the president was, he says, I don't bother myself with those things anymore. They're not important. That might have been a very brilliant answer, but he said that because he honestly did not know. So we can tap into the abilities that people have, daily routines, often remain very intact for people. But one of the things that happens when people with dementia move into a new residential community, perhaps an assisted living or a nursing care facility or a memory care facility, is that those routines get disrupted. And we might think, well, their dementia is just declining, but in reality, it's because the routines and the overlearned practices that they have are not part of the overall flow of their day. People living with dementia can often read well into their disease, into the late stages of their disease. But we have to do a little reading assessment first to know what size font is going to be best for them. And sometimes even the style of font makes a difference in one's ability to continue to read. So the other great thing though, with procedural memory intact, is not only can people continue to do the things they've overlearned throughout their life, they can also learn new things. Individuals living with dementia can learn new things, but it takes repetition. In order to get something to be overlearned, we have to practice it over and over and over again. Great example, I had a family friend named Kathy, and Kathy was diagnosed with dementia. Her and her husband moved into a residential community. Kathy probably had about the middle stages of the disease. And while she was there, one of the things we really understood about Kathy is that Kathy loved to be involved. She loved to be where all the action is. And Kathy always had been an individual who was pretty independent, liked her own way, and some people even called her a little bit stubborn. Problem came up in that Kathy's family decided that the residential community she was currently living in was not a good fit. So they were going to move to a new residential community where there was more activities for Kathy. Sounded like a good plan, except Kathy's apartment was on the 3rd floor, and all the action and all the activities happened on the 1st floor. So when somebody went up to Kathy's room to help escort her and show her the way, Kathy said, "No way. I don't need your help. I don't want anybody's help. I can do it myself." Problem was, Kathy couldn't do it herself, and she couldn't find her way to the 1st floor, and she became very annoyed and very angry, mostly at her husband. So what we needed to do was to come up with a plan that focused on Kathy's assets, particularly the ability for her to learn a new procedure, a new routine. So what I did is I went to the store and I found these footprints that you can buy, and you see him up here on the screen, and they're sticky on the back. And so I peeled off the sticky stuff and I placed them on the wooden floors that were right outside her apartment door. So when Kathy opened up the door, she instinctively followed the footprints. I think that's what we would all do. And guess where the footprints led to? They led to the elevator. And once on the elevator, next to the button that said 1, I put a little sign that said activities, push here. Kathy could read, she could push. And then when she got off the elevator, more footprints leading to where the activities were. And then when Kathy wanted to go back to her apartment, same thing. Followed the footprints to the elevator. I did put a sign in the elevator for a little bit that said Kathy's apartment, 3rd floor. Kathy found the button and would push it and would go. So what happened is that over the next week, Kathy would just follow the footprints and read the sign in the elevator. And she would go back and forth to activities on her own multiple times a day. 2 weeks went by, 3 weeks went by, 4 weeks went by, 5 weeks went by. And on the 6th week, I returned. And I took all the signs out of the elevator, and I peeled up the footprints from the floor. And Kathy opened the door of her apartment one morning to go to activities, and there were no footprints there, and guess what happened? No problem. Without missing a beat, Kathy went to the elevator, pushed the right button, went down to activities. The ability for her to do that routine was now so well wired in. We had connected all the neurons that we needed to, but the most important thing is we had enough time and repetition. Kathy didn't even realize that she had learned something new. So there's so many great opportunities when we really think about applying something like this. In residential communities, using signage, using feet, using, I call them templates, which may be pictures or signs or words that give people instruction and information and cues and allow them to stay more independent and feel a greater sense of self-efficacy. But as I sort of said, you have to do a few things. You have to recognize that this takes time. You may need to use aids like I did with the footprints. And the other really important thing is if you're going to do something, teach something new, you have to make sure that your training and the way you're repeating it is the same all the time. And I share that because a lot of times when I work with staff in residential communities, they have a great idea like this, but it's not being implemented the same from one staff person to the next. And so the ability to really make that work definitely is at a disadvantage. So staff have to really be on the same page. Here's another asset that people living with dementia have, and that's the ability to be creative and to be imaginative. Dementia does not take away creativity, imagination, or curiosity. And in fact, some people, like my colleague Bruce Miller, think it may even be enhanced in people living with dementia. He says that creativity is an area of strength spared by the disease. And for some people, their creative ability is even enhanced. And you'll see this, and for those of you who've been working in the field of dementia know that artists and art sorts of programs really are beginning to be more and more recognized because of the ability for people living with dementia to fully engage. There's one example, there's a choir some of you may be familiar with called Giving Voice. And I think there's about 3 or 4 choirs in the Minneapolis area right now. And we just started one a few months ago in Rochester called Resounding Voices. And these are professionally led choirs that learn new music, sometimes in 2- and 3-part harmonies, and go out and give phenomenal performances in the community. And here's the really cool thing. I had a colleague friend of mine a number of years ago say this. He said, you know, Angela, you have a good arts program when there's no dementia in the room. And what he means by that is when you're engaging in the arts, it's often difficult to tell who has dementia and who doesn't, because the ability to be creative, curious, and imaginative is not something that's impacted by this disease. Here's another area of strength, for better or for worse. It's called emotional memory. Give you an example. The University of Iowa, a number of years ago, engaged in a bit of research that I think is just fascinating. And they went to a residential community and recruited about 13 individuals with middle to advanced stage of dementia. They broke those 30 individuals into 2 groups, and each group watched a movie. But the movies were not the same. The first group watched a movie that makes us feel really good when it's all over? Do you know what movie this is? Up. This is the movie Up. But you can think about any movie that you've watched that you just leave and you're sort of over, your heart is filled with goodness and joy. That was one group. The other group watched a movie, and pick your movie, but for me, any movie where an animal dies is really, really sad. I don't get over it for a lot of days. So they watched the two movies. One made you feel good at the end. One made you feel really sad at the end. Once the movies were over, the 30 individuals got a quick little 10, 15-minute break and then came back to the room where the researchers wanted to ask them some questions. And one of the first questions they asked was, tell me a little bit about, the movie that you saw. Well, here's the thing. Many of the individuals didn't remember that they saw a movie 15 minutes ago, much less remember any details about it. And in fact, that was true in both groups. But honestly, that's not what the research was going after. The research was really looking at something that I like to coin as emotional residue. In other words, how did that movie make them feel, and how did that impact them going forward the rest of the day? And here's where they saw something magical and profound. Those individuals that watched the movie that made them feel good, as they were observed throughout the rest of the day, had increased participation in the activities that were going on, were more social, ate better, and slept better that night. The individuals who watched the movie that made them feel sad were much more irritable, angry, less likely to want to participate in activities with others. Oftentimes, I hear family members who will say something like this to me. They'll say, Mom's in the nursing home and I go visit her, once or twice or 3 times or every day. But she doesn't remember my visits. So I'm not sure, it's really sad to go visit her, so I'm not sure I'm gonna go as much anymore. And if I tell that to a staff person, that the daughter's not gonna come as frequently, this is a common statement that I get. Oh no, the daughter has to come and visit her mom, Marge. Because when the daughter is there, Marge loves it. And when the daughter leaves, Marge is in such a happy place all day long. Now, Marge will still say throughout the day, I wonder when my daughter is coming to visit. She never comes. She doesn't remember the visit. But emotionally, it's like taking that magic pill that puts us in a good mood. So our emotions and where we store emotions and how we feel about certain things is not impacted by this disease. It might be why sometimes I've heard people say, I don't know why he's holding a grudge or she's so angry. She can't remember the incident anyway. True. But they will remember how something made them feel. I love what Maya Angelou says. I've learned that people will forget what you said, they will forget what you did, but they will never forget how you made them feel. I think that's true for all of us, not just people living with dementia. Here's another asset. It's around communication. Individuals with dementia, even advanced dementia, understand certain kinds of communication called nonverbal communication. Whether or not you're living with dementia, you get what this woman might be trying to communicate, right? Somebody living with dementia will feel, will get, will identify disgust with this face, right? Show individuals living with dementia any one of these 6 gestures or facial expressions, and something is going to be communicated to them. So here's the thing about communication, is that for all of us, and I'm not just talking dementia here, we understand more through nonverbal communication than through verbal communication. Even while I'm talking here, if you're normal, your brain is normal, you're probably about 50%, maybe even a little bit more of the time, tuned out to what I'm saying. And your mind is going someplace else. It's just what we habitually do. 55% of how we understand what somebody else is trying to say to us comes through their body language. And 38% comes through tone of voice. Only 7% of communication truly relies exclusively on words. So in my mind, that provides a huge opportunity for us to communicate with people living with dementia. Don't need to worry much about words. What you do need to be concerned about is the body language you have at any moment and the tone of your voice. Tone of voice is very primal. You know, even young animals, puppies, who still haven't learned a lot of words, although they're smart and they will over time, but when they're young, they know when you're happy and they know when you're angry at them. And it doesn't have anything to do with the words you're using. It has to do with the tone of your voice. Another asset, something called mirror neurons. We are hardwired with these mirror neurons. There's been some interesting research a number of years ago on them, and it looked at how babies mimic facial expressions, right? Hardwired. So we know if they're hardwired, they're likely to not be lost in the face of dementia. So kind of keeping that in mind. So for a lot of years, I teach yoga, and then I also taught yoga to people with mild cognitive impairment as well as a very advanced dementia, and also people in the community who don't speak English. And so one of the things I rely on is demonstration. And when I'm leading a yoga class with people who have dementia, and it's combined with people who don't have dementia, if I'm using a lot of demonstration, you wouldn't be able to tell who has dementia and who doesn't, because everybody can respond and follow. If I'm only using words, yeah, you might be able to tell. And finally, I want to talk about something else that's hardwired. And here's where I'm going to start to get into more the why this matters to those of you out there who are caregivers, and how can your job be made more easy. We all have basic human needs, right? The need for shelter and food. But we also have, all of us, there's research out there to substantiate this, we all have basic emotional needs that we have throughout our life. 7 of them are talked about in research a lot, and I want to highlight a few of them. We all have the need to feel respected. We all have the need to have a sense that we have choice and control in our life. We all have a need to feel that our life has purpose. And we all have a need to feel needed and to feel like we are contributing. People living with dementia have these needs as well. And these emotional needs do not go away in the face of even advanced dementia. Do you think people living with dementia know when they're being treated with respect and when they're not? Usually they will let you know if they're not feeling like they're being treated with respect. Dr. Richard Taylor, diagnosed with Alzheimer's disease, died about a year ago. I love this statement that he made. He said, "I believe that as people progress with dementia, their humanity increases." In other words, those basic human needs, I think, become even more real and necessary. So when I say need to feel respected, just a couple of things that I mean here. I mean seeing the person first, not his or her disease. When I worked at Charterhouse and was helping to support their communities of people living with dementia, I'd often go up to a staff person and I would say, "Hey, tell me a little bit, I know Dorothy just moved in. Tell me a little bit about Dorothy." And the staff person would likely say something like this: "Well, she moved in 3 days ago. She, takes 6 pills this time, at this time, and this time. She needs to be turned, a couple of times. She's got this diagnosis. She's on a diet that looks like, these kinds of foods." And I'm like, and I will say, no, stop there. Tell me about Dorothy. Who is she? And then oftentimes they'd be a little bit stumped in order to really be able to share with me who that individual is as a person. When I had people coming into the program that I created at Mayo Clinic a number of years ago called the Habit Program, it was for people with dementia or mild cognitive impairment and their spouses. And one of the things I asked is, for as long as possible, I didn't want to know which part of that dyad, the husband and wife usually, or husband or wife and their partner, I didn't want to know who had dementia and who didn't. Because I wanted to make sure that I was not imposing some self-fulfilling prophecy and beginning to think about the capacity that people would or would not have because of something that my mind might have believed. This is what Sylvia says. "I am Sylvia. I was Sylvia before I was diagnosed, and I am still Sylvia after being diagnosed. I'm the same person. Treat me in the same way. Talk to me in the same way. Include me in the conversation as you would have before." One other thing I'll say under the need to feel respected is to treat people, those living with dementia, like an adult at all times and under all circumstances. And one way that we sometimes get tripped up on this, and this is sometimes just has to do with older adults in general, but there's something out there coined as elder speak. And what this sounds like is that your voice changes, the tone of your voice changes, sometimes the pace of your words change, sometimes your words change, and it sounds like you're speaking to a young child. Do you know what I mean? Do you know what I mean? Sometimes I'll hear people in care facilities talking to somebody, and I'll think, it sounds like they're giving a tour to preschoolers or something like that. Or it sounds overly directive. I want you to, you need to. Or it sounds like you're answering for that person. Now, you don't really want to do that, no, do you? Baby talk, patronizing, demeaning. There was a study that was done that was published in the Journal of Gerontological Nursing that showed that when it came to giving people with dementia cares, which I know can be a difficult thing to do anyway, that what made the biggest difference in individuals reacting with irritability, anger, agitation, or resisting cares had to do more with how that caregiver was talking, both verbally and non-verbally. The need to have choice and control, another human emotional need that does not go away in the face of dementia. So when I say these statements, imagine what a person with dementia, or just imagine what you are hearing. I want you to. It's time to. You need to. We need to. No. Not like that. You can't. I'll do that for you. Do you think think this might be what somebody living with dementia hears over and over and over again? In many instances, it is. What is that person essentially hearing is, hello, I'm in charge of you. Sometimes I'll have care staff say, so-and-so gets really agitated. At the end of the day, they call it sundowners, and I don't buy that where the sun is in the sky has anything to do much with people's behaviors. I think by 3 or 4 or 5 o'clock in the afternoon, hearing, I want you to, you need to, let's do that, let's go to the bathroom. That's one that annoys me more than anything else. I don't go up to my women friends, right, Mary Kay, and say, let's go to the bathroom. But we do that with people living with dementia. So how do we give back choice and control? Because sometimes we do need people with dementia to do certain things. So if we can't tell them what to do, or if we know that that's going to disempower their personhood and create irritability and agitation, how do we do it? So let me just give you some examples. So over on the left, here are things that people might hear that really don't offer much choice and control, telling people what to do. Let's get your robe on. I'll cut that up for you. I'll bet you'd like the television on. It's time to go to the bathroom. Common statements that in and of themselves may not seem like they're going to be all that negative, but accumulated over the course of the day, yes. So here's some different ways to think about it that give an individual with dementia an offering, a sense that they're in control and they have some choice. Instead of let's get your robe on, may I assist you? May I assist you? I was visiting a residential community in Boston, and there was this gentleman there who'd been working there for 10 years, and he was a personal care aide. And he was really tall, a little bit intimidating, and they called him the dementia whisperer. And he had this reputation because over the 10 years that he had worked there, he had never had a resident resist cares or become agitated in his presence while giving cares. So we're like, we have to meet with him, we have to know the secret sauce. And again, very intimidating looking guy at first glance. And very soft-spoken when we sat down with him. And he said, the only thing I always do is ask permission. May I? May I take your arm and assist you to the bathroom? May I help you over to the toilet? May I hold this while you sit down? Instead of saying, I'll cut that up for you, again, we're well-meaning when we do things. But if you were sitting at a restaurant or out with friends and somebody leaned over to you and said, I'll cut your meat up for you, I don't think we would care for that much. How about, would it be all right if I cut up your slice of turkey? Would you like a little assistance with some cutting up of your meat? Instead of, I'll bet you'd like the television on, let me turn it on for you. How about, what do you think about having the television on? Instead of, it's time to go to the bathroom, or let's go to the bathroom. Do you mind if I walked with you to the restroom so we can keep chatting? Getting the same thing accomplished, and there's more than, one way to offer up choice and control. But I just wanted to start to give you some examples. One of them that I often hear from care staff has to do with trying to get somebody to have a bath or a shower or something like that, right? That can, and I don't know about you, but if some stranger that I didn't know came into my bedroom and said, I'm here to give you a bath, I would get really angry and agitated and fearful. And I might get even a little bit aggressive if they started to take my clothes off and I didn't know who they were. I don't know, Susan, would you? Yeah. But yet people with dementia do it, and we write in their chart, resisting behaviors wouldn't let me give them a bath, right? But there's some ways to do it that begin to build rapport and trust. And instead of saying, hey, I'm here to give you your bath or your shower this morning, maybe you say something like, Judy, I'm here to assist you with your spa today. And if you're ready now, I'll assist you. But if you want me to come back in 5 minutes, I can do that too. And Judy's not quite sure, so she says, oh yeah, come back in 5 minutes. And so then I go back in 5 minutes and I say, hey, Judy, Angie again, this is the time you ordered up your spa. I have the vanilla bath salts and I have the lavender. Would you give them a smell? Which do you like best? You see where we're starting to create a very, very different experience, one where Judy feels in control. Here's a few more. You need to take your medications. How about, can I get you some water to take with these medications right here? Instead of, I want you to sit over there. Do you prefer to sit on the couch or in a recliner? You don't really want to go to that concert now, do you? Maybe you say, what's your opinion on the outdoor concert? What's your opinion? What's your opinion on this? People living with dementia may not be able to tell you what they had for lunch today, but they'll be able to give an opinion on just about anything. Different part of the brain necessary for that. Instead of saying, no, don't do it like that, you might say, oh yeah, oh, and there's another way to do it. So it's this I learned this skill from improv folks. Improv folks, professionals, are very used to just taking whatever the audience gives them and never telling an audience member they're wrong, because then they're not going to get much participation. So they always agree and say yes and. Yes and. Love that. So the need to have choice and control. Here's sort of the punchline. Ask. Ask. What do you think? May I? Offer choices. Would you like this or that? Do you prefer this or that? Include in decisions. What's your thought? What's your opinion on something? And here's that adopt a no wrong way spirit. Yes and. True or false? Dementia causes anger, agitation, and other negative behaviors. False. Thank you. The real truth is that most distress, and by that I mean anger, agitation, irritability, aggression, most of that distress arises when an emotional need is being threatened. Not just because they have dementia. That distress is probably the same distress you and I would have in a similar situation, being told what to do, when to do it, having a stranger come into our room. So when I talk with families or go out to care facilities, residences, and I'm talking to staff or families about some distress that they're noticing, let's just say agitation. First thing I think of is that definition. Dementia is a shift in the way the person is experiencing the world around him or her. That opens up my mind to, I wonder what they're hearing. I wonder what they're seeing in their environment. And I begin to very quickly begin to come up with some possible solutions. But here's the checklist in my head. When somebody says, I don't know why so-and-so is agitated, my head does this. My checklist. Are they feeling shamed or humiliated in any way? That loss of dignity or respect. Are they being told what to do? A loss of choice and control. And number 3, what is that person doing throughout the day? Is it meaningless activities like folding towels over and over again? Or is it something that's really purposeful for them? For right at about 12 years, one of the roles I had with some of my other colleagues in the Department of Neurology is we had a team called the DBART team, which stood for Dementia Behavior Assessment and Response Team, and we would go out within about a 90-mile radius of Mayo Clinic when people would request it, specifically to help troubleshoot irritability, agitation, anger in residents. And so we collected a lot of information, we collected a lot of data. And one of the things that we looked at was, well, what is the most common cause? What's the number one reason for irritability, anger, and agitation? And apathy fell into that one as well. And there was one that really rose to the surface. Any idea what? Loss of dignity was there, but there was something even more obvious than that. Purpose. It was boredom. Boredom. What we found was that people who were most irritable and agitated and anger, frankly, if you looked at what they had going on over the course of the day, it was little to nothing. And if you think about it, some of them had loss of mobility. Think about this for yourself. You don't have the ability to get up and go places. You're in a wheelchair. And throughout the whole day, there's really not a whole lot being offered up for you to engage in that's meaningful. Tell me how you'd feel a week, a month, a year into it. If not agitated and angry or hostile, probably just pretty hopeless and apathetic, right? The person living with dementia is not unhappy or upset simply because of their disease or any of you. They are living with unwanted dependency and loss. What they need more than anything else is to feel useful, respected, and loved. This is what gets me up in the morning to do this work. I know that there's no cure for this disease right now, but it's not hopeless. Because the quality of somebody's life living with this disease is so intertwined in their ability to feel useful, respected, and loved. And that's a hopeful message for me because that's something we can give. Need to feel that life has purpose, need to feel needed. Probably a month or so ago, I came up to Minnetonka, and there was a group of guys that call themselves the guys, and there's 5 of them, and they are all living with some cause of dementia, most of them Alzheimer's disease, I think Lewy body disease with one of them. And anyway, they've been meeting at the same restaurant in Minnetonka now for probably close to a year. And as I sat there with them, I could tell that they had pretty advanced dementia. And I asked them to, on a scale of 1 to 10, to rate the quality of their life at that point. And here's what they said. They all first agreed that they couldn't give one number, but it would be a range. And so one gentleman said, 5 to 9, and somebody else said, 3 to 7, and somebody said 8 to 12. Sometimes it was off the charts. And so I said, so what made a day a 3-day versus a 9-day? And here's what they also said, and totally were in agreement with this. They said a 2 or a 3-day is a day when they feel like they are a burden to someone else. And it was a day when they felt bored. So what made a 9 or a 10-day? They said a 9 or a 10-day is a day when I feel like I am making some kind of contribution. The basic human experience that I think defines all of us, especially all of us, myself included, as we get older, and I really think about what's important in my life, I come back time and time again to a sense of meaning, purpose, and contribution, just like people living with dementia. and so much that we can offer them in this space. So the need to feel that life has purpose, the need to feel needed, I think our job is to recognize and support the need that people have to contribute, to focus on what they can contribute around versus what they can't. And it might mean, you know, a little more creativity and a little more thinking and maybe collaborating with other care partners. Avoid assuming that the person is incompetent or cannot. When we think somebody can't do something, it influences our attitude and it influences our behaviors. We believe what we tell ourselves, and then we behave accordingly. So never make assumptions about what somebody with dementia can and cannot do. And I see this happening as well with well-deserving spouses. The spouse, one of them will get dementia, and the well spouse starts to take over and do things for. And not only does that maybe perhaps cause irritability and agitation with the person living with dementia, it may actually foster dependency quicker than it may otherwise. Encourage and praise often. Those words will go so far in the life of an individual with dementia in terms of well-being. And communicate wisely. And by this, I mean not testing. So I'm going to pick on you two, and I wish you had name tags, but you don't. But you guys can team up together. Here you go. Oh, I wish you could see their faces right now. What is the name of the 8th planet from the sun? I'm going to give you 4, 3. Pluto? Are you sure? No? You look confused. You both look confused. How about this one? What is the capital of Oregon?
Portland.
No. Bzzz. No. What significant event in U.S. history happened last week? Now you got to know this one. All right, I need a photograph of that because her eyes are big, they're kind of shaking their head, they're a little bit red. Look at the redness on her neck. Yeah. So the purpose of this isn't that you actually knew the answer, and in fact, I sort of put things up there that most of us might not know the answer to. I think the capital of Oregon is Salem. Yeah. I don't know what the 8th planet from the sun is, and I don't know what significant event, if there was any at all last week. I just put that up there. Yes. But I did that to give you a sense of what people with dementia might feel like when you ask questions like that have a right or a wrong answer, or ask questions like, "Do you remember?" Right? All of a sudden, you start to panic. And you started to feel like, I don't want to make a fool out of myself. The exact sort of reaction and agitation and uncertainty, I think, that we're going to get with people who have dementia. So how do we change our conversations so that they're less likely to create that look that I just saw on those sisters' faces? So the questions that I put on the right are examples of questions that rely to some degree on the hippocampus memory working. So have you seen a good movie lately? I mean, somebody with dementia could just say yes or no and kind of make something up and maybe save face that way. But if they have, the reality is they probably don't remember, and they may know that they don't remember. Who painted this picture? Again, right or wrong, most of us might not even know the answer to this. Do you remember who came to see you today? They have Alzheimer's disease, it's impacting the hippocampus, probably don't know. Or, hey, I noticed this room is a different color. When did you paint it? So if you want to begin to create an uncomfortable relationship and rapport with somebody living with dementia, ask questions that have a right or a wrong answer, and you'll do that. Instead, think about these no-fail conversations that rely more on imagination, curiosity, opinions. Do you enjoy going to the movies? Not putting anyone on the spot, right? How does this picture make you feel? What do you see? Is there anything strange about this picture? Would you want to go there? Would you hang this in your house? How much money would you pay for this? All of those questions can spark a great dialogue with somebody living with dementia, and not one of those questions required a hippocampus that is working. Do you remember who came to see you today? Instead, how about, it looked like you were enjoying your visit with your brother today. You see where you're providing a cue? He seems like a pretty funny guy, is he? Or instead of, when did you get this room repainted? Well, what's your opinion on this new paint color? It looks different from the last time I was here. What do you think about it? Does that make sense? Yeah. This is a daughter who we coached on communicating with her mom, who every time she went to visit was an irritable visit for both of them. And when she changed the way she communicated, she said this: "This has been the most delightful visit with my mother in years, not because she changed, but because we did." So over the last almost 2 decades, I've been connecting with caregivers, helping to facilitate supportive gatherings with caregivers and support groups. And one of the things that I came to realize was that caregivers share a lot of similarities in terms of what they're going through. And even in the face of a lot of similarities, I began to get very curious early on in my work with caregivers, because even though their situation in a lot of ways was very similar, there were differences in the way that caregivers experienced their situation. In other words, some saw this caregiving experience in a very dark way, and they just seemed to spiral in this place of darkness. And then there were the other subset of caregivers who seemed to have this resilience, that even though their person that they were caring for, was progressive and having the same kinds of functional challenges, the two caregivers were very different in the face of this. And here's one of the things that I identified early on. Was one of the things that separated the caregivers who found this place of resilience from the caregivers who just were spiraling down deeper and deeper was something called acceptance. Acceptance is not liking it, agreeing with it, or giving in or giving up. That's not what I mean by acceptance. It's letting go of the need to control something that you can't. It's letting go of the need to control and making peace with what is. One of the caregivers said this: "I find calm when I stop trying so hard to make things different." So when I talk about acceptance in the context of caring for somebody with dementia, there's all kinds of things that we begin to accept with this disease, and these are just a few common themes that I've heard from caregivers. Accept that a diagnosis with all its implications will have a profound impact on your marriage, relationship, or friendship. There's no other way around it. There's no other way around it. It will change, and it will have a profound effect. Accept that you will not be perfect, and you will get angry. Some of the caregivers that I've spent time with who struggle the most are caregivers who have an expectation of themselves to be an A+ caregiver. The caregivers who seem to have much more resilience are caregivers who accept being a C- caregiver. And accept that everything changes. This is the wonder of impermanence that I think is so difficult in so many transitions in our life. The opposite of acceptance is resistance. Resistance creates suffering. Acceptance eases it. Doesn't change things, but it eases it. So one other thing that I've gotten very interested in trying to really help caregivers find this place of acceptance and not continue to go in the spiral of darkness. And one of the things as well that caregivers do who overcome the challenges of caregiving, recognize that often it's not the actual situation that causes the stress. Because what I said before was many of the caregivers that I've been with have the same stress, yet the stress levels are very different. And one of the things I've identified that separates those two is the way they think about things. Hence, mindfulness-based caring. So I've been focused on looking at mindfulness for caregivers as a practice now over the last couple of years. And some caregivers, the more I learn about mindfulness, either have had a mindfulness practice all their life or a great part of their life and now find that it has a great purpose in their current situation. Some people just naturally do this, sometimes even without recognizing it, and others have found that learning this has been significantly valuable in their own well-being. And I'm not going to talk tonight, because I know I've talked a lot already on mindfulness-based dementia caring, but if any of you have any questions or want to know more about it, I'm certainly happy to talk more about it with any of you who are interested. But this is my favorite definition of mindfulness. I know it's not Jon Kabat-Zinn's definition, and for those of you who know mindfulness, you know his definition, but this is the one I like the most as it relates to the caregiving experience. And it says that mindfulness is simply being aware of what is happening right now without wishing it were different. Just sitting alongside the sadness or the difficulty without wishing it were different. Mindfulness is enjoying the pleasant without holding on when it changes, because it will. And mindfulness is being with the unpleasant without fearing it will always be like this, because it won't. So before I open it up for whatever time we have for questions, I want to end by offering up a mindfulness practice that I've used in my own life for a lot of years, and one of them that I teach caregivers. And it's actually one that I learned from a woman named Kristen Zeff. And Kristen is out of the University of California, San Francisco, and if you're interested at all in mindfulness, or actually her main work is in self-compassion, and Kristen Neff, N-E-F-F, has a wonderful book called Self-Compassion, and she She had a child who was autistic, and so through her parenting and love of her son, really had to begin to look at ways to move through that experience in a way that was good for everybody. And so one of the things that she talks about in her book are these self-compassion breaks that she would take in a lot of different moments when she began to see a situation unraveling, and she knew there was nothing she could do to control it. So if you're so inclined, this will take about 60 seconds, and here's what I would invite you to do, and that is just to get comfortable in your seat and uncross your legs if you're okay with that. Sit back in your seat so that you can really feel the back of that bench supporting you. Let your hands just rest for right now, just gently on your lap. Tuck your chin and drop your gaze a little bit, and if you'd like to, close your eyes. And then take a really deep breath in through the nose, so deep that you're going to feel your belly expand and rise along with your rib cage. And then open your mouth and exhale all the air out and just sigh, feeling yourself being rooted into the ground, into that chair underneath you. And what I'd like you to do now is to take one hand and place it on your heart, and take the other hand and place it on top of that, and just add a little bit of pressure right onto your heart. And to bring to mind, for this moment, something right now that is causing you some pain. And just be with it for a moment, see it. Allow that feeling to have a space to breathe in your body right now. And I'd like you to say these words to yourself. This is a moment of pain or suffering. Suffering is part of the shared human experience. I am not alone. May I give myself the compassion I need. May I find ease. You can let your hands fall down on your lap, and blink open your eyes when you're done. So Kristen Neff, as do I, uses this quick little self-compassion break at multiple times, sometimes multiple times a day. When I sense in my body, usually for me it's in my belly, I get these belly aches. Sometimes I feel it in my jaw or my shoulders, and sometimes I just notice my heart begin to beat a little bit quicker, and I know that I'm starting to get a little bit worked up. And if I'm in a place where I can close my eyes, I will. If I'm in a place where I can just take my hands and place them over my heart, I will. But just saying these words provides some space for me to breathe for a moment, to give myself permission to feel whatever I'm feeling, and then to allow it, as it oftentimes does when I do this quick self-compassion break, to move through me.